We all know no two people are the same, and it turns out neither are our responses to medication. Let's take a look at how pharmacogenomics can help guide doctors to prescribe medications that actually work for you. Meet Alex and Maria. They're coworkers, both navigating life's ups and downs. But recently, Maria's been on a journey that's raised an unexpected question. Why do two people that take the same medication get completely different results?
Hey Maria, it's great to see you. How have you been feeling?
Better now, thankfully, but honestly, it has been a rough few months. My doctor put me on sertraline for depression, but it just didn't help. I was actually feeling worse. I felt nauseous all the time, and I don't think I slept properly in weeks.
That's strange. My sister's on sertraline and she says it's completely turned her life around.
Exactly. That's what confused me. Then my doctor switched me to fluvoxamine, and suddenly I started feeling like myself again.
So, it's the same kind of medication, but it was a totally different outcome?
Yep, same class even. I couldn't figure out why.
Maria's experience isn't rare. Every year, countless patients find a medication that works for one person but doesn't for another. The reason often lies deep within our DNA. Every cell in our body carries DNA, the blueprint of life. Inside that blueprint are genes, each containing instructions for making proteins. These proteins do everything. They carry oxygen, send signals, repair tissue, and help us process medications. But not all genes are identical. Small spelling differences, known as genetic variants, make each of us unique. Most of these differences are harmless, but some can subtly change how our proteins function. And when those proteins are the ones responsible for breaking down medications, even a small change can make a big difference. So let's pause for a second. If every person's DNA is slightly different, what do you think that means for how we respond to medication? A, everyone should take the same dose. B, some people might break down drugs faster or slower. Or C, genes don't affect medication at all. Exactly, genetic differences can change how fast or slow we process medications.
So, did your doctor ever figure out why sertraline didn't work?
She did. She mentioned something called pharmacogenomic testing, a DNA test that looks at how your genes affect your response to medications.
Pharmacogenomic testing often focuses on a special group of proteins called the cytochrome P450 enzymes, or CYP for short. Think of these enzymes as the body's chemical factories, constantly transforming medications so they can do their job or be safely cleared from the body. Two of the most important are CYP2C19 and CYP2D6. Together, they handle nearly a quarter of all prescription drugs, including many antidepressants, painkillers, and heart medications. Some people inherit versions of these genes that make the enzymes work differently. For example, enzymes can work too slowly, causing drugs to build up in the body, which can increase side effects or make the treatments less effective. Or enzymes can work too quickly, breaking down the drug before it has a chance to work properly, which can reduce its effectiveness or increase side effects in some cases.
My test showed that I have variants in CYP2C19, which apparently is involved a lot in the metabolism and breakdown of sertraline. It turns out I'm what they call a poor metabolizer. My body breaks down and clears the drug too slowly, which causes it to build up and cause all of the side effects I was feeling. But fluvoxamine uses a different pathway. So once I switched, everything started working and I felt so much better.
Wow, so it wasn't that sertraline was bad, it was just the wrong match for you?
Exactly.
Maria struggled because her body processed sertraline too slowly. But let's flip the scenario for a moment. What do you think would happen if Maria were a fast or even an ultra rapid metabolizer instead? If she metabolized the drug too quickly, her body would clear it before it had any chance to work. She would barely feel any benefit, or maybe even think that the medication's doing nothing, all because the drug wouldn't stay in her system for long enough to reach effective levels. What Maria experienced is the essence of pharmacogenomics, the study of how our genes influence the way we respond to medications. It's part of a new era of precision medicine where instead of a one-size-fits-all approach, treatment is often personalized based on each person's individual genetics. Let's look at a different example. Take codeine, a common pain reliever. The body must convert codeine into morphine for it to work, and that conversion depends on the CYP2D6 enzyme. If someone's enzyme works too slowly, they may feel no pain relief at all. That's how the same medication at the same dose can produce completely opposite effects in different people.
So, pharmacogenomics mostly just affects how drugs are broken down or cleared from the system, right?
Correct, but there's more. What you're talking about is something called pharmacokinetics. But pharmacogenomics also involves pharmacodynamics, which is the effect of the drug on the body and how it helps symptoms after being metabolized.
This is so complex.
Alex is right, this is a complex subject, but let's break it down. So, we already know that pharmacogenomics is the study of how our genes influence the way we respond to medications, and it can be broken down into two areas. The first is pharmacokinetics, which is what the body does to the drug, how it's absorbed, distributed, metabolized, and eliminated. Pharmacodynamics, on the other hand, is what the drug does to the body, how it targets cells and influences biological responses. Like in Maria's case, the biological response was the release of a happy hormone called serotonin to treat her depression symptoms. Genetic differences can influence both. That's why two patients taking the same pill can have completely different experiences. For decades, prescribing medication has often been a process of trial and error. Doctors would start with one option, wait a few weeks, and adjust it if it didn't work. Pharmacogenomics changes that. With a simple cheek swab or blood test, clinicians can identify how a patient's genes affect drug metabolism. Patients are then categorized as poor, intermediate, normal, or ultra-rapid metabolizers. This helps physicians pick the right drug and the right dose from the start. Hospitals and pharmacies around the world are beginning to integrate pharmacogenomic results into electronic health records, allowing future prescriptions to automatically account for a patient's genetic profile. One last check-in. Pharmacogenomics mainly helps doctors A. Guess which drug might work best, B. Match the right drug and dose to your genes, or C. Eliminate the need for doctors altogether. Correct. Pharmacogenomics supports smarter, personalized choices, not guesswork.
That's incredible. I never realized our DNA could play such a big role in how we react to something as common as an antidepressant.
Same. It makes me think how many people might be on the wrong medication just because of genetics.
Pharmacogenomics doesn't replace good medical judgment, but it adds a powerful layer of understanding. Genes are just one part of the story, along with lifestyle, diet, and environment. Still, by learning how our DNA shapes our response to drugs, we're moving from average medicine to individualized medicine. Alex and Maria's story reminds us, sometimes it's not that the medicine is wrong, it's just the wrong medicine for you. Because in the end, your DNA doesn't just make you unique, it can help make your healthcare unique too. Thanks for watching. If you would like to learn more about pharmacogenomics, here are some helpful general resources. The links to each resource are available in the description.
If you want to start with another simple, easy to digest introduction to pharmacogenomics, you can start with the Osmosis PGx webinar and the NIH Pharmacogenomics fact sheet. If you prefer something more health-focused, Medline's overview and the Sick Kids PGx page are solid places to explore how the testing actually works.
For anyone with a clinical background or anyone who wants to go deeper, we've also provided some resources at the bottom. We will end the webinar with a short walkthrough of ClinPGx, so if you'd like, feel free to stick around for a quick tutorial. This tutorial is not medical advice. Please refer to your physician or genetic counselor for official advice on pharmacogenomics and medications. This is a sample pharmacogenomics test report that you get back. The first column to look at would be gene. which is the instruction manual for protein or enzymes being built. In this case, we can see that there are 3 genes, CYP2C19, NUDT15, CYP2B6. The second column is genotype. We have 2 copies of each gene in our cells, one from mom, one from dad. And these are also called alleles. For a pharmacogenomics report, the genotype is mostly written in a star allele nomenclature. Looking at the first row, the first star allele is star 2, the second star allele is star 3. Moving on to the third column, phenotype, it is a description of how each allele impacts protein function and enzyme activity, which in this case leads to both alleles not functioning and producing no enzyme. The last column is status, which is the overall effect of the 2 alleles on the protein function or enzyme activity. If you wanted to know more information about this result, you would go to ClinPGx, which is the most comprehensive source for pharmacogenomic information as of now.
Okay, so this is the homepage of ClinPGx. It brings together multiple trusted projects into one place, and the goal of that is to essentially make personalized medicine more accessible and to support its use in everyday clinical care. On this homepage, we see that there's individual repositories for different aspects of pharmacogenomics, such as drugs or genes. But since we have a result from a genetic testing report that we want to explore further, we're instead going to go to the search bar at the very top. Okay, so we'll start by searching CYP2C19 as well as sertraline, which is the drug that Maria used in our video. However, you can search for each term separately if you wanted to. So this takes us to this page here. So this is the overview page. It includes hyperlinks for each search term containing very specific science details in the background for each one if you needed this. But we're going to go right ahead to the second tab, which is the prescribing info tab. This tab contains the bulk of that important actionable information that you or either your physician would need, and it also contains clinical prescribing guidelines. These guidelines are curated by international PGx expert groups. So for sertraline, if we scroll down, we can see that we have actionable guidelines from 2 different sources. We're just going to go ahead with the CPIC guidelines. So that takes us to this page here. This is where we're able to do something very cool. We can actually input our genotype from the report in order to pull up relevant information from the CPIC guidelines. So we know we have a star 2, star 3 genotype, so that's exactly what we're gonna input here. So star 2 for CYP2C19, and then star 3. And then we can click on Find Results. Okay, so this page shows us all that relevant information for this genotype and drug combination. The CPIC guidelines off the bat shows us that there are 2 actions, so we can either go with an alternate drug or we can alternate the dosing for the drug. The phenotype shows poor metabolizer, as we expected, as this is what we see in the report. The implications show that poor metabolizers may experience increased side effects because of the buildup of the drug in the body, as we saw with Maria. And then the recommendations, which is what the doctor will be looking for, say to either lower the starting dose or select a different clinically appropriate antidepressant that isn't fully metabolized by CYP2C19, which is our quote-unquote broken gene here. So in Maria's case, that was fluvoxamine. Okay, and if we go back to our original search, the next tab is the drug labels annotations. This provides annotated FDA-approved medication labels that go on the actual medication packaging. It contains concise information on how a patient's genetic variations may affect their response to a drug so that healthcare providers can easily and quickly understand it. And then the next tab is the Summary Annotations tab. This shows the level of evidence the star-allele-drug relationship has by summarizing information from peer-reviewed literature and clinical guidelines. So there are 6 categories of evidence levels from 1 to 4, where level 1 shows the highest level of evidence and level 4 shows no evidence. Level 1 and 2 are also split into A and B subcategories based on whether they have prescribing guidance yet. Knowing how strong the evidence is for a pair could really inform prescription decisions by your doctor. Our star allele genotype and sertraline have a level 1A evidence score, which means it has the strongest level of evidence and it has prescribing guidance from clinical guidelines. And these next 3 tabs here are if you want to delve into scientific and research-based information for the search, which you are more than welcome to after this tutorial.
That is all for this tutorial. There are training resources available in the Educational Resources section on the homepage that you can access to help familiarize yourself with the ClinPGx website. Thanks for watching!